Well, thank you everyone for joining us. It's really excellent to see you all here today, and lovely to see so many people from across the globe. So I'm Trudie and I'm speaking to you from the Global Health Network, and I'm really delighted to be introducing Vasee today, whilst we host this talk for him to explain the World Health Assembly resolution on clinical trials to us all. So Vasee is the Senior Advisor for R&D for the WHO's Research for Health Department in the Science Division in the World Health Organization in Geneva. So Vasee is going to explain us all around the World Health Assembly 75.8 resolution on clinical trials and the global consultation that they have planned for its implementation. This is such an important session, and we're really delighted to host this because this resolution should have a really positive impact on research across the globe. And it's really important that we have a really wide understanding of what it means and how it could be implemented and have a chance to contribute. So this is going to be a very useful session, and I hope you all contribute in the questions and in the chat that's going to have happen at the end. We've got plenty of time set aside for this. So just a little bit of housekeeping before I hand over to Vasee. Firstly, this session is being recorded, and we're going to be sharing this on the Global Health Network after today. So plenty of people hopefully can see this after we've recorded it. There's a Q&A and a chat function, which you can find in the toolbar. So please post your questions as we go, because we'll collect these and put them to Vasee to take at the end. And we can also keep these for referring to later. So don't worry if you don't think we have time to get to your question today. So it's my absolute pleasure to hand over to Vasee. Do post your questions up. It's really important to hear from you all. And I hope you all enjoy, as I'm going to, into listening to Vasee and explaining to us all about this really important resolution on clinical trials. So over to you, Vasee.
Thank you so much, Trudie. Can you hear me okay? Yeah.
Yeah, all good.
Great. It's such a pleasure to be here to try to explain to you all where we are with the clinical trials resolution. Thank you for joining. Good morning, good afternoon, good evening, for wherever you are joining around the world. I know that there are so many competing events for you all, so I really appreciate you taking the time to join today. I hope that you will agree by the end of the presentation that there's an opportunity with the resolution to develop new guidance from WHO to support the conduct of clinical trials. This is the first time since 2005 the World Health Assembly has requested that WHO develop clinical trial specific guidance. So it's not something that comes around that often. Please do think about whatever questions that you're going to ask at the end, so that we can try to have a little bit of interaction at the end. And as Trudie said, the slides and the recording of this presentation are going to be made available. So let's see if I can share the slides. So just first of all, a background on what the World Health Assembly is, in case any of you are not aware. We at WHO, and I'm based in the headquarters in Geneva, report through our governance structure to a board and the broader assembly. The assembly consists of the 195 member states that we have, so one delegate each from each of the member states, and they set the agenda and they instruct us as the Secretariat on what our actions are going to be for the next year, as well as evaluating our progress against the agreed objectives for the year before. And in 2022, this resolution on clinical trials was adopted. Adopted means that it was agreed by all of the member states. So that means that all of the governments of the world essentially have agreed on this resolution. The key features of this resolution are that it calls for governments to acknowledge the central role of randomized controlled trials in the health sector in generating knowledge for decision-making. And I'll go through the background in some slides after this. It highlights major needs around design of research capacity, better evidence for underserved populations. So those are the three key sections that the guidance is also going to focus on. It identifies needs to improve prioritization, coordination, and quality of research. And it calls for national authorities and non-state actors to focus any randomized controlled trials on the key aspects needed to generate needs-based high-quality evidence, as well as, so the first point is before the guidance that I'm going to talk about, the WHO has been instructed to develop, there are already a set of actions that the resolution encourages national health authorities, research funders, research ethics constituencies, national regulators, universities, including the private sector. There are certain actions that are there already that are suggested. This is not binding, but it's an indication that this has been adopted by all of our member states. Then most of my presentation is going to focus on where we are with developing WHO guidance on design quality, strengthening the clinical research ecosystem, and filling gaps in evidence in underserved groups. So some of the background is, as with much of what is happening in health at the moment, is a reaction to what happened during the pandemic. So this is a graphic from our COVID-19 living guidelines for therapeutics. This is from a few months ago, so it may not be completely up to date, but the point still stands, which is that these are areas where we have strong recommendations, either for or against. There are other areas where we don't have strong recommendations. Where there are strong recommendations, this means that there is considered to be high quality evidence. In many areas, we don't have strong recommendations because there isn't considered to be high quality evidence. And if you look at the evidence that was generated, that was reviewed and assessed as being good enough quality to lead to strong recommendations, you would see that from the more than 18,000 clinical trials that were conducted during the pandemic on COVID-19, a very small proportion, less than 10%, probably far less than 5%, led to this high quality evidence and the strong recommendations. And some of those trials were publicly funded and coordinated, and some of them were privately funded and sponsored. So really some lessons learned of successful approaches from both the public sector and the private sector. Some of those publicly coordinated and funded trials were adaptive platform trials. And you would have heard of some of these, Recovery and Solidarity, for example. Now, by contrast, the majority of the clinical trials that were done provided no useful evidence. And this is one analysis from these two authors. Janet Woodcock is a senior FDA member of staff from the USA. And through their analysis, 95% of randomization arms in the COVID-19 trials were essentially designed to fail. And this paper came out in the course of the pandemic while many of these trials were underway. And these tended to be either because they were too small, or they didn't enroll the numbers that they planned to enroll, which happened for the majority of trials, or there were certain design elements, such as, for example, the endpoints or the outcomes really not being relevant for decision-making. Another key issue, of course, in that those of you from developing countries around the world would be very well aware that there are major discrepancies in research capacity by countries around the world. And if you look at one very crude indicator, and it is crude, but it's an indicator, is the total numbers of clinical trials. Of course, not only clinical trials are important for generating important knowledge, and that's something that I think I need to highlight. WHO itself is not through this resolution specifying that it's only clinical trials that are important, but the resolution is focusing on clinical trials. So that is why my presentation here is focusing on clinical trials. So if you look at this metric, and there's a link here that you can click on after you get the slides. In the WHO Global Observatory on Health R&D, there are numbers for the total numbers of clinical trials for any disease or condition. And the data source here is our International Clinical Trials Registration platform, where we receive the registry details from almost all clinical trials around the world, or all of those that are entered into registries that meet our standards. You'll see that there are many countries where a lot of progress has been made over the last 10 years, but there is still major gaps in terms of the numbers of trials in different parts of the world. And there are some countries or sub-regions where there are almost no clinical research that we've been able to identify. So that's all a very important part of the background to what led to the resolution. So member states initiated this and then went through a set of negotiation sessions that arrived at this text. So that's important to be clear about. This was driven and led by the member states themselves, not by the Secretariat. We are following the requests to us that are in the resolution. And one of those requests is mapping of existing guidances and resources related to clinical trials. So if you haven't seen this website, any of you interested in clinical research should look, in that we, as part of the first request for mapping, we identified all of the guidances and resources that were highlighted to us through a public consultation that occurred in October and November of last year. And so this is a good starting point for understanding what the current baseline is. We are commissioning further mapping and more detailed reports on the baseline, which we will be reporting to the board in January 2024 as requested. But just for an example, we identified 112 clinical trial networks. So one of these networks may have over 100 sites and many countries, but we identified 112 non-communicable diseases and infectious diseases, both endemic and epidemic. And already looking at that list, and we'll work on a narrative summary of this as part of the next steps. You can see where we have at least some reasonable networks in place and other areas where we don't. And one interesting point that follows from this is that in some parts of the African region, we have a reasonable number of networks now, whereas by contrast, our Eastern Mediterranean region, which spans from the western part of North Africa over to Pakistan, really has much less in terms of research networks than the African region, the Afro region. For example, the Caribbean seems to have very little in terms of research. So that's already helpful to see. In terms of baseline, we also received input to a set of questions that we asked about the status of the clinical trial ecosystem and next steps for guidance that were perceived to be needed. 273 comprehensive sets of inputs were received, and the ones that we received permission to publicly disclose in full are on our website. But all of these have been collated into a long summary. And a couple of points there are that we, in our development of guidance, must ensure that it is complementary to existing guidance. That's laid out clearly in the resolution, most notably with regard to ICH. But in addition to ICH, there are two other guidances that are relatively recent that are really very relevant. One is a CIOMS, that's the Council of International Organizations of Medical Sciences, guidance on clinical research in resource-limited settings in 2021, and another one developed by a group called the Good Clinical Trials Collaborative. This is in addition to existing core ethics guidances, such as the Declaration of Helsinki and a CIOMS ethics guidance from 2016 that anybody in clinical research would be familiar with. So in our guidance, we are explicitly building on this existing guidance. So we're not reinventing anything. I mean, it's 2023, so there's clearly a lot of guidance that's already around. In the longer report, there's also quite a lot on the status in various areas and examples of best practices in areas on these slides, but also highlighting some major gaps in what are the needs for clinical trials in resource-limited settings, and quite a few gaps in terms of RCTs done in various subpopulations, for example, in children, in pregnant and lactating women, and other groups, antigen-specific groups such as AMR and neglected tropical diseases, and the R&D blueprint list of emerging infectious diseases and others. So I'm not going to read this out, but you will have the slides. This is wording on the guidance that we are to develop and that we're in the process of developing. couple of key points are that it is to focus on steps that need to be taken to strengthen infrastructure and capacities and to provide guidance for clinical trials in normal times, but also with provisions for application during a public health emergency, because we saw that it's very much the capacities that already exist that can be redeployed in terms of emergencies. So an important lens on resourcing capacity development in normal times is also thinking that this is the capacity that will be available during emergencies. As I said, we're instructed to really take into account relevant existing initiatives and guidances, including ICH. And we are to develop guidance both for member states themselves, but also for non-state actors and various types of non-state actors, including national health authorities, research ethics constituencies, national regulators, research funders, and others. And all this is going to be done through an extensive consultation process. And this webinar is part of that. And we're very grateful to the Global Health Network for helping us to raise awareness of this process and really let you know that there is going to be guidance, draft guidance available for public consultation later this year. And I would really value, and WHO would value, that you get the message out that we're really looking for input on the draft guidance from everyone once it's available for consultation, which we hope will be the third quarter. I think I've already gone through this. As I said right at the beginning, the guidance is going to include 3 key sections. Implementation of scientifically and ethically appropriate clinical trials. So guidance on design and implementation, that will be the first section. Strengthening the clinical trial ecosystem, the second section. And then how do we address underserved populations will be the third section. And in terms of the timeline, there are many staff internally at WHO that are involved in consultation. There will be a 0 draft reviewed by a technical advisory group, which is constituted now, and the members are publicly now disclosed on a website that we've created. It's very carefully geographically balanced and gender balanced. There are more women than men. So the version that includes their inputs will be put out for public consultation, and will engage beyond the public consultation on our website, where anybody can come to us. We'll also be engaging systematically with all of those key groups that I referenced: regulators, ethics groups, clinical researchers, funders, the private sector, and also certainly looking for patient organizations, public engagement, community engagement. And then further drafts will be developed, and we don't have a timeline right now for when this will be finalized, because that really depends on the input that we receive during the public consultation. And sometimes with these types of documents, we have another round of public consultation if needed. And it also depends on the input that we receive from our board when they review the progress, which will be in January. So it certainly will not be finalized this year. A question that is sort of live at the moment is the extent to which we will develop implementation guidance by regions, for example, adapted as needed for different types of trials or different geographical needs. And if there is a demand for that, and we can find the resources to develop that kind of implementation guidance, then we will do that. We're keen that there is, first of all, as much input from constituencies in different countries around the world working on different types of trials. I mean, this guidance needs to be as relevant in Malawi as it is in Manchester, let's say. And it also needs to be equally relevant for a cancer trial that is being set up in India as it would be for a leishmaniasis trial that was ongoing somewhere in Africa or Latin America. So it's really very important that we take our time to receive this input. I think if we do our job correctly, then there may be quite some demand for implementation assistance as this proceeds. And I think one of the other important points is how do we anchor this guidance in the research ecosystem more broadly? The scope of the resolution is very clearly focusing on randomized clinical trials. So that is what we will do. But of course, it's understood that countries, low to middle income countries that are seeking to improve their research ecosystem will not exclusively be focusing on supporting their clinical trials ecosystem. So we will need to think how to anchor this into the broader research ecosystem work. And just to close, that this is the overall website that we will keep updating, that has the resources and the mapping that we identified and the longer report. We have a generic email address that you're free to contact myself and also my colleague, Dr. Wei Zhang, who has joined recently to support with next steps with the resolution. So I'll stop there.
Thanks, Vasee. We've got a question up straight away from John, who's from Sierra Leone. I don't know if you've seen it, but I'll read it to you. So John asks, he says, thank you for the explanation with your presentation. And you talk about capacity building for low resource settings like there is in Sierra Leone with John. So he's asking, how is capacity building being implemented, and is it tailored with the Ministries of Health or the WHO country office? So that's a really great question, John.
The next steps are, John, thank you for the question, are for us really to develop essentially a normative guidance from WHO on how countries can advance their clinical trials research capacity, covering all of the different pillars. And we will, in the guidance, refer to probably 4 pillars that need to be developed in order to enable good quality, needs-based clinical trials in different countries. Now, in some areas related to clinical trials, WHO already has quite granular guidance on what countries need to do. That would be in the areas of the national regulatory authorities, improving how national regulatory authorities for medical products can improve their own functionality in how they oversee clinical trials. That's already available. There's something called a global benchmarking tool for national regulatory authorities. So really the idea here is to develop a broader set of normative guidance that not only spans how national regulators can improve their functionality, but also how research ethicists can for clinical trials, how clinical researchers themselves can, how governments can, if they choose to follow the guidance, support universities and other clinical research institutions, as well as individual clinical researchers in gaining the capacities needed for clinical trials. And the focus is really going to be on the key needs for design and implementation to generate locally relevant evidence. There have been sort of different interpretations of what we mean by quality. Focus here is on the key types of data that need to be collected, the key features that WHO recommends are followed in order for the evidence to be useful for decision making. So once that's available, then we hope that that's going to be helpful for all of the different groups that would be involved in research capacity development. So it should be helpful for research funders internationally, as well as domestic authorities in the next steps. And so there clearly would be actions for the Ministry of Health. The WHO country offices will be involved. And actually, something I didn't talk about is that what we would like to do is have some pilot discussions in specific countries while this is still in draft, so that it is written in a way that is really useful for countries at different capacity levels around the world. And so in your question, what's the role of different groups, that will also partly come from the piloting work that we would like to do.
Thanks, Vasee. John, you might want to let us know if that answers your question, and do you could be, just to say as well, people can also put their hands up, and we can field your questions that way if you've got some more. I've got one as well, Vasee, but I'll wait for a minute. So the anonymous attendee has asked if ICH GCP is already implemented for clinical trials in most countries. Why does the WHO need to implement a resolution for clinical trials? Well, that's an excellent question, Vasee, and I know you've got a lot to say on that. So I think that's a really good point about the role of ICH GCP relative to this. So a good question, whoever posted that.
Yeah. So, well, first of all, it's very clear in the resolution that we are to work closely with ICH. And so we're not going to be contradicting anything that is in ICH. So let's be really clear about that. We're already in touch with the ICH Secretariat. If those of you who are familiar with this area will know that the E6 guidance is going through its third revision, R3 process. There's going to be a public consultation on that later this year. So we will stay closely in touch. Some of the areas there are quite aligned actually with some of the areas that the resolution is referring to. So for example, in the resolution, it does highlight the fact that we should acknowledge that there are innovative trial designs and there are what might be considered less traditional ways of designing or collecting data. For example, decentralization of elements of trials, moving away from like a rigid interpretation of the idea of clinical trial sites in some ways, digitization, data collection by health workers rather than full-time researchers, all of those sorts of things. I think they are thinking about in the R3 revision process of ICH. So I think the important point is that this guidance is not going to mean that people don't need to look at the ICH guidance, but the ICH guidance is at the level of individual clinical trials, where the data, it's clinical data that is for submission to medical product regulatory authorities, the national equivalents of FDA in the US or EMA in Europe, for consideration of licensure or marketing authorization for medical products. There are, if you're looking at individual clinical trials, there are many clinical trials which are not conducted for that purpose. And those clinical trials are not the intended area of application for ICH. So for example, behavioral interventions, and let's just take, say, mental health as one area. There are many types of RCTs which don't include any medical products at all that are looking at behavioral interventions. So part of the background is the need for overarching guidance that covers any kind of randomized intervention. Secondly, there are many trials that are led by generally publicly funded or coordinated trials that are really not looking at questions around initial licensure of medical products, but are looking at different types of questions that health systems need to make, decisions that health policy planners need to make about combinations, for example, of interventions, or about looking at interventions in populations that have been neglected previously. So there are all sorts of other types of clinical trials that the current system really hasn't been addressing appropriately. And also let's bear in mind that, as I said, there were more than 18,000 COVID-19 trials. The vast majority of them were not useful. So whatever the existing landscape of guidance is, and this is not a criticism of any of them, but the reality is that in the situation with the existing guidances that we have, it did not prevent the situation where, by most analyses, over 90% of over 18,000 trials didn't provide any useful evidence. And then finally, we're also asked to really look at the whole level of the ecosystem and infrastructure strengthening, which is really not within the scope of, let's say, ICH E6. So I hope that answers your questions. But as I said, we are closely in touch with the ICH Secretariat, because I think it would really be a disservice for the clinical research community if there was any confusion about the relative roles of different guidance documents, and we are committed to avoiding that. Thanks.
Thanks, Vasee. Yeah, I think that was a really good answer. It's a very complex landscape, isn't it? I think your last point to me seems the most it is where this should really bring some clarity, that ICH is there to be interpreted, as you said, for each individual trial. And what the resolution is trying to do really is create that systematic support, isn't it, across nations, and really enable clinical trials to happen really well in every setting. And in fact, that's where I wanted to ask a question really about where you think this could really bring something quite unique, and what we've been working to for a really long time about, equity and where trials happen. I mean, that graph you showed at the beginning from the observatory, I think was just, says it all, doesn't it? So I think how do you think we could harness the intent of the resolution to really address some of that inequity? And I think that also does answer the difference between ICH is there to guide safe, ethical, and accurate trials at an individual level, but how can we really harness this to drive equity, do you think?
I think it's a great opportunity, and this all will depend on the inputs that we receive from people working at the front line. None of this can be decided by somebody sitting in Geneva, but it's a great opportunity to look at what is really needed. If those on the call here are I'm seeing questions from Nepal, for example, in places where maybe the capacity is not so high. The general perception is that there's a very high bar for doing RCTs, that there's a lot of bureaucracy and paperwork, you need a lot of money. But at the same time, if you want to really generate evidence and answer questions about what are the interventions that are going to benefit the health of local populations, in some cases, you need to be involved in RCTs, where you don't necessarily always need to repeat RCTs in your country, but there might be some questions that can only be answered in your country or in your region. So what we would like is to really take this opportunity to think at what are the critical issues beyond, the vast reams of guidance that we have. I mean, if you had to read all of the existing guidance, it would probably take you quite a long time. But if we take a step back from that, what really are the key features? What are the key scientific features for reliably informative trials? And what are the key pieces of data that need to be collected? So I think what's in line with the resolution is trying to simplify, in a way, all of the different procedures and try to address and it does talk about excessive bureaucracy. It talks about streamlining. Right now, we have situations where there are just too many approval bodies, for one thing, that need to approve. We sometimes have 20, 40 approval bodies for one trial. And beyond a certain point, that is not adding anything to the quality of the trial or subject participant protection. So I think there's real opportunities to streamline and focus on the key areas that are needed. And from that, hopefully it'll help resources be focused on the key needs. So we really hope that it will lead to a better equation between the resources going in and the usefulness of the information that's generated.
Two questions. A really great one from Nepal. So Navneet has said that Nepal is developing a clinical trial ecosystem and has huge challenges such as ethics, approval times, and the regulatory processes. So how can you overcome the regulatory challenges, which I know you just touched upon?
I think there's one good model, something called WHA. I don't know if the people who are listening are familiar with it. I think some of the Africans will be. What's interesting is that if you look at the models for streamlining the approval procedures, Africa is actually ahead of everywhere. It's ahead of Europe, it's ahead of North America. In Africa, and it's something that has happened over more than 10 years, this project called AVREF, which is facilitated by a WHO team, but working very closely with national regulatory authorities and research ethics committees, And in that model, what you can do, I think, some things can't be streamlined. So maybe one should focus on what logically can be streamlined. And one of the things I think is where you have contradictory questions coming from different approval bodies, which I think still happens quite a lot because they don't talk to each other, and the time frame that it takes. And the time frame is very important to think about, not only how long it takes for the approval bodies, but how long it takes for the research team to reply. Because I sometimes see a lot of focus on the approval bodies, but then the research team takes a long time to answer the question. So I think everybody needs to be accountable for how long they take. And in AVRF, what happens is if there are, let's say, 20 NRAs and ethics committees, they all are in touch with each other to review the protocol, and a single list of questions goes back to the sponsor. So that means that the questions are not contradicting each other because they've been in touch with each other. And then there's a time frame that is specified for how long each of the bodies has to review the revised protocol afterwards. So I've seen that really does accelerate timeframes a lot. But one of the things that I've seen is that the regulatory coordination, as far as I can see, is actually advancing more quickly than ethics committee coordination. And that is also partly because I don't think there is enough focus on resourcing for the ethics committees as well as the regulators and the researchers. I'm not sure if the researchers, if they agree with that, but unless everybody is adequately resourced, then we can't expect the quality of the review to improve and the timelines to be as fast as we'd like. So I think one of the things that the guidance may highlight is the need for all of these different groups to be resourced, but then maybe in their monitoring and evaluation, once they're resourced adequately, there needs to be a focus not only on how many questions are asked, but on proportionality and efficiency and timeliness of the procedures.
Thanks, Vasee. Right, let's go back to Awezo. You are, the mic is yours. Would you like to ask Vasee your question?
Hi.
We can
Hello,
hear
we can hear you.
Yeah, my question is why the WHA is adopted and then there is some irregularity or options by WHO.
I mean, it was initiated by the member states themselves, because that's how these processes work. One of the member states tables a draft resolution, and then they go through a negotiation process. And then if they agree a text, then they adopt a resolution. And I tried to explain the background to this coming out of the pandemic.
Thanks, Vasee. Yeah, I think that does answer it. I think it sounded to me when it was why do we need it and why is WHO taking it forward, which I think that's exactly right. A really straightforward one, I hope. Will this cover the clinical trials of medical devices?
Yes, well, the definition of clinical trials here is any prospective, any design with prospective randomized assignment to at least 2 arms. So an observational study is not included, with 1 or more intervention arms concurrently and at least 1 control arm, which may be the existing standard practice in that setting, or maybe a placebo, for example. So if that type of design is used to evaluate a medical device, then yes, there will certainly be some medical device RCTs that are included, and it would apply to essentially every medical product class, including in some cases diagnostics, in vivo diagnostics, in vitro diagnostics. Although I do think if you look at ICTRP, the majority of the clinical trials that we have are related to medicines or therapeutics in some way. And all of these other areas are the minority, including preventive, such as vaccines and diagnostics and medical devices.
Great. So now there's a bit more around coming back to implementation, I think. So we've got a question from Irenas Sayori. So thank you for your presentation and looking forward to contributing, which is good because that's exactly what you want, isn't it? Lots of contribution. It's a very complex landscape to navigate. And so just wondering how WHO plans to develop a guideline that works for diverse settings. And wouldn't it be more useful if the guidelines are contextualized regionally?
Well, that's a great question. As with all of the questions, we will need to have this balance between being so high level that it's doesn't really have any content and being too granular and prescriptive to make it counterproductive for a global guidance. So we're not going to go into too much detail. Whether or not there should be regional adaptations of it, I think it is possible that if the regional offices in WHO and the key stakeholders in the regions don't think that the global guidance really is adapted enough, that we could develop some specific implementation tools, for example. But first of all, we will try to make any implementation tools globally applicable. Clearly, translation is a major issue. So that's one of the things that I hope we'll be able to do once we get to the right time. The overall guidance will be translated into the 6 languages, for sure. The implementation guidance, it might be that some parts of it, there are calls for more details, and where there are calls, then we always try to meet them and maybe adapt them to some extent and translate them into specific languages where there are calls for them.
Excellent. Francisco has got a really great question. Francisco works for Médecins Sans Frontières Access Campaign. So Francisco, if we give you your mic, would you like to answer the question, ask the question directly? Because I think it's a really important one.
Thank you very much, Trudie. Thank you very much, Dr. Vasee. So my question is really straightforward in the sense of looking for clarity if this work from WHO, very important work, is going to be mainly led through the mandates given by the current resolution that's being discussed, that has been approved in the last WHA, or if it's aiming to encompass other important mandates that were given to WHO to work on clinical trials. Particularly, I was mentioning the request for additional transparency of clinical trial costs as mandated by a resolution in 2019. And because, as you know, there hasn't been, although this is an important mandate, there hasn't been sufficient discussions amongst member states on this resolution, and even in the process leading up to the approval of this resolution, it was even in the last minute, including the agenda, jumbled up together. So it's a mix of a matter of process, but also in terms of clarity and transparency of the work going forward. Thank you.
Thanks a lot. That's a great question. What we will do is we will look, we will really be judged by our own governance processes on what we have done with regard to this resolution. So we have to report back to our board and assembly on what the Secretariat has been asked to do for this resolution. But we're asked to develop guidance related to clinical trials. So we will be referring to other existing resolutions so far as they are speaking to clinical trials. So anything that is something that has come out of WHA related to clinical trials, we will look at that and we will consider what is appropriate to include.
Thanks, Vasee. That's great. So we've got Yoni has been waiting patiently, and I think we're going to pass Yoni the mic.
Thanks. Here is Yoni. I'm actually the manager of Blue Cloud Africa, and we've been supporting sites of excellence for clinical trials. And what we realized over this period is how do we make patient centricity at the center of your resolution, so that the patients are the focus of more of what has been done in clinical trial, moving away from data, real-world data and data that has been a focus, more important than how we treat and care for patients in clinical trial. And do we see the resolution also go into how do we make clinical trials more decentralized in their outfit? How do we make them more accessible to the populations who are originally unable to access clinical trials? Are we going to adopt more modern tools to allow that? And are the resolutions that you're looking at similar tools, modern tools to allow participation in clinical trial? Thank you very much.
Thank you so much. Well, I would just ask you if you could please plan to work with your constituency, with the patient engagement constituency, around looking at the draft when it comes out, because I think we do need to be forward-looking. You know, clinical trials, we saw with the pandemic that if you look at the recovery trial, I think at one point they had something like 20% of all the people admitted to a large country with a particular syndrome were being enrolled in the trial. And the data was being collected, you know, in a routine healthcare setting, essentially, largely by health workers who were not full-time researchers. And that turned out to identify an intervention, glucocorticoids, that probably saved, you know, many, many hundreds of thousands of lives. I think some of these estimates are even millions of lives. So that was not a very traditional RCT. So, and things are changing. So I really think it's important that we try to include some elements, forward-looking elements that allow for, I mean, the key question really is, whatever the population is that requires evidence to be generated to support their needs, how can we do it? Rather than making people go to a fixed site somewhere, how can we collect data wherever they are? And one of the things that people have discussed quite a lot is that there isn't enough in terms of community-based data collection. There are places where it's just completely unfeasible. I lived in Africa, in South Africa and Gambia for 5 years in fairly remote settings. I'm sure there are much more remote settings than where I was. But it's great to think wherever you are, how could we ensure that it's possible to collect data reliably, to answer the question reliably. And it would be great for you to look at what will go out and see and propose how to improve it if it's not good enough. But we're going to try to include those elements.
Thanks, Vasee. We've just got time for a couple more questions, always towards the end. They come in thick and fast, but do please still type them up, because if we don't have time, we're going to collect them all for the WHO team, so they've got them. And Vasee, I'm going to save time at the end for you to answer Patrick's question right at the end about what happens after this meeting, because that's ideal. So we'll pass the mic to Reveline, and then we'll have the last question around how difficult it is when there's lots of apathy to trials in Nigeria, which is, I think that's just such a great question and true in so many places. So should we pass the mic to Reveline, and then we'll come back to Rufina. Thank you.
Hi, good afternoon. Hi, Trudie. Hi, I'm not sure how to pronounce the name of the presenter. That's really different. But
don't worry, it's fine. I answer to anything.
Oh, okay. So my question centers around whether the guidelines that we are hoping to develop for the clinical trials will be something that would be implemented across various countries. And the reason why I'm asking, and again, I'm looking at the diversity and the fragility of some of the regulatory bodies and the current guidelines in Africa. So if you look at Africa as a whole, in terms of regulatory guidelines for conducting clinical trials, we have countries that are far advanced and constantly building capacity. And then we have countries where the guidelines are at the best rudimentary. So if we are hoping to standardize or come up with some sort of standardized guidelines, are we going to be having like a guideline that's available? Because I know currently there's like a WHO GCP guideline that countries can choose to adopt, but then there's also the GCP, ICH GCP. So then taking into account if countries are using both guidelines and standard ICH guidelines, will there be a way in which they have to choose which one to implement, or it will be a standard that if we are going to conduct, for example, clinical trials in Africa, we go with the country guideline, but the basic overall presiding guideline with the one provided by the WHO? And then how are we going to implement or take into account the very, very different regulatory framework within the countries that are participating, or countries that are working with guidelines? I'm not sure if my question makes sense, but yeah.
That was clear. Yeah, it's a very, very good question. What the only analogy that I think I can give you is in the global benchmarking tool for regulatory systems, there are maturity levels. And so it's articulated in such a way that it's meaningful for countries that are at the very, very lowest levels up to the highest levels. So if we get to the stage of developing implementation guidance, so that would be if it's clear that there's support for that along the process, then in that implementation guidance, we can structure it in the same way. It needs to be applicable to countries really at the very low end. So if there isn't one research ethics committee that is really able to review protocols in a country, that's one of the first things that you want to do. If you don't have one clinical research institution that can support developing local researchers, then when you get to high levels of capacity, you get to these questions about coordination, prioritization, collaboration, communication, the networks, and how all of the different elements can more efficiently work with each other. So we do plan that the way that we're going to do this is going to be written in such a way that it's specifically will have parts of it that speak to countries or stakeholders at different points in their journey of strengthening their capacity, if you see what I mean. And in terms of which guidance, I mean, it's really for the countries to decide what they choose to follow. But like I said, there is no intention here that this is going to replace ICH GCP. I mean, essentially, in many settings, or most settings, for medical product data, it is already the case that you need to follow the ICH guidance. And so we expect that will continue, and we will make sure that our guidance is complementary for other types of purposes, for the ecosystem as a whole, for interventions that are being studied for different purposes.
So Vasee, we've got 2 minutes, and I'm going to try and get you to answer 2 questions in one, because it'll help us wrap up too. So just to say, I think that pretty much answered Rafina's question around gaining support across a country like Nigeria where there's apathy, but you touched on the ethics point there. So Mariam Hassan from Pakistan has asked a really interesting point about translating trial results into policy and practice, and that whole ecosystem of taking, what do you do with making sure the evidence is used. And if you could just tie that in with Patrick's question about what happens next after this meeting in terms of your implementation plans, and then we'll wrap up. You've got a minute.
Sure. Well, translation is really important, but I think one of the areas that is likely to be in the guidance is to lay out some expectations for capacities that are required in a country that, first of all, allow for prioritization, so that RCTs that are supported really are meeting local needs, are starting with what patients and communities actually need, and then the evidence that relates to translation, because if the trials are meeting local needs and take into account what the policymakers are asking for, it's much more likely that the policymakers will enact on the results. So we will try to lay out some high-level guidance on how to build both prioritization and translation better into the way that the resources are spent at the moment. But it's a really very important point. In terms of the next steps, so as I said, we have an external technical advisory group that's already set up, that maybe we can share the link for who those folks are. Once they have reviewed the very earliest draft that we have now, that will go out on our website. I don't know exactly when it will be, but we're aiming for the third quarter of this year. It will be on the website. And around that time, and it will be up for 2 or 3 months. So it won't be just a short period. We'll really be seeking input. And we're planning on developing a questionnaire, so that not only posting a PDF, but also a questionnaire, so that we can try to structure the input. And then based on the input we receive, we will develop it further, and there will be further drafts. But at that public consultation phase, we'll be planning regional workshops. So there's actually a plan with the regional offices in at least PAHO, EMRO, and AFRO that we have face-to-face regional workshops. And we won't be able to invite by any means everyone that would like to come, because we need to have all of these different stakeholder groups that are represented. But we'll try and seek input before those workshops from a broader group using a questionnaire type of approach. So basically, lots of watch this space, draft material coming, and we're really looking for your input. And thank you all so much, and you're all doing such important work, and we're really looking forward to your input into how this can be useful.
Thank you, Vasee. I think everybody attending really appreciated really getting that level of understanding on the WHA resolution. And certainly we'll be recording this, and so we'll make sure that we put this out as widely as possible so that everybody else can see it too. So thank you very much. And thank you for all the questions posted. And we look forward to hearing more, and good luck with taking this forward.
Thank you. Thank you, Trudie, and thank you to everyone for joining.